There is no head-to-head comparison of one agent versus the other. All we have are the clinical data from separate clinical trials, and it's always difficult to do cross-trial comparisons. So what we have to decide as clinicians is, when we have nivolumab and pembrolizumab, for instance, as a comparison, can our patients come to the clinic every 2 weeks as required by administration of nivolumab versus every 3 weeks as required by pembro? So some of it is the schedule of delivery of the drug. I think clinicians who believe in the biomarker as being the sole decider as to whether somebody should get immunotherapy or not would choose that, so that if a patient does not have any PD-L1 level expression, it might not be offered immunotherapy in certain settings. Although again, we have data that in all comer patient population, the drugs can be effective. So from a clinical decision-making process, most patients who are now in the second line, as long as they have reasonable performance status and we think they can withstand any potential toxicities that could arise, I think that would be a good candidate for treatment with these agents. I don't differentiate between PD-1s and PD-L1s. I don't have necessarily a favorite one versus the other. But again, if a patient is coming from 3 hours away and coming in every 2 weeks is hard for them, then I have the option of using an agent that's given every 3 weeks. So basically, that's how I would select my patients.